The PCN DES contract has dropped, and as a result of that, we've got loads of information that's come out that basically you probably need to know the impact of how this is going to work in general practice. In this episode, myself and Andy are going to cover the headline documents, going to talk through QoF QI a little bit more as we try and help demystify this whole process for all of you in terms of what general practice is looking like in the new world of 2022-2023, general practice and primary care networks. Let's tech enhance your primary care and learning. Hey GP learners, thank you for joining us on this lovely Saturday morning, and we are going to be going through basically the headline stuff about the PCN DES contract for 2022-2023. We're going to go through the main letter and then talk about some of the QoF QI portions in particular, and then in subsequent episodes of the next coming weeks we're going to be going through more detail, including the various added elements of the PCN DES and basically hopefully everything you need to know to get yourself set up for the next year in PCN DES world, and there's so much in there, isn't there, Andy?
Yeah, there's an awful lot going on. So a few weeks ago, NHS England dropped a number of new documents onto their website, so there's plenty for us to go through over the next few weeks and possibly months. Gandhi, if you want to just bring them up on the screen.
Yeah, so there we go. So as you can see, lots of stuff there.
Yeah, so and in particular today, we thought that we'd focus on the cover note for the Network Contract Direct Enhanced Service changes, which is a really good place to start. It gives us a good indication of where NHS England feel the areas of focus should be for the network DES, which obviously tells us how we should be running our primary care networks, essentially, where the areas of focus should be for the next 12 months. It highlights what's staying the same and also gives us a heads up as to the main things that are changing in the DES. And then there's all sorts of supplementary documents which we will be working hard to go through with you over the next few weeks.
Yeah, so those of you who are long-time followers of eGPlearning will remember this time last year we did pretty much the same thing. We looked at structured medication reviews, we looked at care home enhanced service and all the other elements. So we're going to be doing similar things over the coming weeks. So unfortunately, this episode is not going to be the all-encompassing thing because, to be honest, to do everything in one go will probably take us several hours, and you won't want to watch that, to be honest.
Yeah, I think it would just be too much to do all in one go. So let's look at the areas and of focus and priorities today, and that'll give you a good idea in terms of what we're going to be focusing on going forward. So shall we jump in?
Yeah, let's go for it. So we're going to cover the main kind of like PCN DES letter. So this is the updated version that came out on the 31st of March, dropping the day before the contract starts. It seems to be trend with NHS England, isn't it, effectively?
It is, yeah. They like to keep us on short notice, and they like to not give us much warning when they're going to change things. So this is the cover note. So this sort of is the note that kind of wraps up all of the other announcements together. It's quite a short document, about I think 7 or 8 pages. And I guess if we just dive in, as ever, I think these are a nice way to encourage viewers to actually pick up the documents themselves sometimes. Yep.
And if you do want the links to these, we'll put these on the end of the description of the YouTube video in particular, and in the podcast episode as well. So you can have it and get straight to the documents as well. So you can have a look at those as we're going through them if you would choose to, which we would actually recommend because there's some interesting stuff coming up, particularly when we get to the QoF QI bits.
Good. And Gandhi, I just thought, when we're together like this, it feels like we go a lot faster,
Yeah.
I've just noticed we've really dived in to this. Normally we just have a few moments to say, if people out there are watching and they have something that they want to comment or ask, then just pop those in the comment box in whatever platform that you're dealing with, and we can see those come up and try and deal with those as we go through. Might bring your comment onto screen.
And we're just going to do that really briefly because it's an interesting one. And it's not necessarily about the PCN DES, but this is a comment from Liz Hare asking us about when our next Training the Trainers conference is. So just to let you know, that is imminent. It's on the 14th of May, and that's our collaboration work with Tara Jones. And we're going to be having an amazing conference on the 14th of May. Loads of content. I get to show how board games work in general practice training. So yeah, if you want to see that, as well as loads of other amazing speakers, definitely join us. The links for that, again, we'll put down below. But if you search for GP5T3, because it's our third one, you'll be able to do so. And in addition, I'm going to mention it because it's coming up soon. We're doing our collaboration course with Ben Gowland from the General Practice podcast and Tara Humphreys from the Business of Healthcare podcast. And basically, this is our support course for new clinical directors of PCNs, where there are limited spaces left. I think we're almost full, aren't we, Andy?
Yeah, almost there, yeah.
Which surprises, because we've even had to increase the number of people that can join from our original plan just to try and accommodate some extra people. But unfortunately, there is going to be a limit. If you do want to join us for that, the link for that is now on screen, but it's bit.ly/PCN plus, all in capitals. And that will take you straight through to that course, which kicks off the week before the GP5T3 on the 5th of May. So if you're interested in those, have a little look. But let's get cracking with the document, shall we, Andy?
Yeah, so as ever, it's an interesting document. I always take these as a bit of a steer from NHS England and potentially the government as to where they feel the focus should be. These are the documents which are going to be more widely read by the sort of the general media and the general population if they have an interest, more than the nitty gritty. So this gives an indication as to where they feel they want kind of people to focus and what people want to see about what's happening. Yeah, my first comment was, short notice.
Yeah,
they don't give us long, although I think that's ever has been the case in the NHS.
Not this bad. So if you go back pre-COVID, actually the PCN DES contracts and everything else that came out, they came out around about December time. And obviously that was to then kick off in April. Now, we know that there have been some issues in terms of this particular contract and the negotiation of it and the approval by the GPC, and as a result of that, how that's potentially impacted this being possibly the latest contract drop we've ever had. I mean, the day before, you can't really get much later than that, to be honest.
Yeah, you're right. I mean, it's been a bit like this through COVID, but you're right. I think back to the original PCN DES, and actually that came out a few months before.
I think we're just maybe having some Wi-Fi issues, people, so hopefully we'll be back with you in a second if we have lost you, but if we haven't, we're going to carry on, and we're hopefully back now.
Okay.
Not quite sure what happened there, people, but
that's interesting. But yeah, no, I remember when the initial DES dropped, actually, it dropped with enough time for people to actually look at it and see what wasn't workable, particularly around the proportion of ARS staff funding that was provided and the shortfall that was going to needed to be made up by practices. And actually that allowed people to discuss that and change it for the better. So it feels that maybe we're losing something in the ability to maintain quality in the sorts of policies that are coming out if they come out so late. So interesting. So short notice. They're highlighting that to maintain stability and limit change whilst bolstering investment, they're basically trying to limit the number of changes that they are making to the DES, which I think is very sensible. Despite that, they are making some changes and they are putting some additional requirements in there, but they are highlighting that they're trying to limit that. So I think that's interesting and sensible. And then moving through, the next bit of the document really talks about things which are staying the same. So these are things that have already been announced. So the amount of funding available for the additional roles reimbursement scheme is going up by the predicted amount. They are reminding us of that. They're reminding us, and it's interesting that this is a specific point in the cover letter. They're reminding us that there'll be the opportunity to employ a second mental health practitioner within each primary care network. It's interesting that that's made it to the cover letter. Any thoughts on that, Gandhi?
So the interesting thing about this is the availability, I think. So I think they're highlighting it because I think they recognise there is massive shortage in the mental health workforce capacity. So we're trying to, I think, maybe polarise people to think this is one potentially to focus on. I think it's important to, it says on a 50-50 shared reimbursement scheme. And the really interesting part is one word that's changed. It's gone from should to can. So does this mean that actually networks don't have to necessarily share it with the Mental Health Care Trust? And the reason why I say that, I know locally in Nottingham, our local health trust unfortunately turned around to all the networks and said, we just do not have the workforce capacity to give you an additional person to work with in your network. So you're basically stuck at one for this financial year. And this used to say, I think it says should or has to, whereas now it's changed to can. So it's really interesting sometimes when they make these subtle changes and the words that are in there and the words that aren't in there. And unfortunately, it causes lots of chaos and confusion because the time you then have to wait for clarification from a lot of these things is always down to local versus national interpretation. And we're going to see this later on when we talk about network hours potentially. But the fact that that one word has changed I think is potentially interesting, and I absolutely would encourage NHS England to clarify, does this mean, unlike last year, networks had to share it with the mental health care trust? Do they still have to do that for the second person this financial year? Because if not, I think that's potentially increasing availability for networks to access somebody. Or is it still the same situation? They've just screwed up on the wording.
That's really interesting. I'd not picked up on that, Gandhi. But you're right, should and can do have very different meanings. So maybe there'll be some increased flexibility for primary care networks to employ these without a mental health trust, which will be really, really interesting.
And what I would encourage NHS England in particular, if you are going to give clarification, can you please make sure it is overarching clarification? I remember in previous years, it's taken us months to get clarification on subtle word changes in the contracts and stuff locally, because it's everybody's interpretation, as we said. So be very clear when it comes to announcements about these kind of things.
Yeah, good. They go on to again confirm, and I think these things have been announced already, the funding available for leadership and management within primary care networks, including the funding for the clinical director role, which continues. Gandhi, is that the same figure as it has been before, or has that changed? You've often got an eye for these figures.
I believe it is the same figure.
It looks the same to me.
0.736, yep, that's correct. That's the same amount of funding that we had previously.
Okay, so no inflationary uplift for PCN clinical directors, I guess, but still good. I was going to say good. Is it enough funding for leadership in primary care networks? It's always been a bit of a stretch, really, but there's a further £43 million to be divided up, nationally and regionally down to individual primary care network level for some additional leadership and management resources, which I think is welcome. And
I think in many networks, what we'll probably see is that being used to supplement the role of things like the network managers, and many networks are now big enough to necessarily need. And we've talked previously about the value of that. Tara Humphreys has talked massively about that and has her own course to help new network managers in terms of supporting that. So it's good that there is funding identified to support this kind of stuff. As many people have criticised numerous times, this should have been there at the start, and it shouldn't be an additional bolt-on. But hey, we're where we're at.
Yeah, and it's also helpful if these things are recurrent, particularly if you are wanting to employ a person like a network manager. A good quality person isn't necessarily going to move from their existing role into a network manager role without that funding being recurrent. But it's reminding us also that there's the £1.50 per head recurrent funding for primary care networks, and I think largely a lot of networks will have funded their managers from that funding, which is recurrent. So I guess additional monies are welcome. So again, that's saying so. Another thing, which again is not new news, but is highlighted in the letter, and I think potentially because access is such a hot issue politically, is what is happening around enhanced access, and the extended hours and enhanced access are being combined. The funding for that is being combined, and the whole thing is to be delivered together by primary care networks. And we went into some detail about those announcements a few weeks ago, but they're basically reminding us of those announcements and those requirements. I don't know if it's worth spending a bit of time on that now.
So do feel free to go back and watch our previous episode, which came out a month ago, that talked about the original letter when it came out on the 1st of March. There's not really any significant changes, but there's one interesting thing that I've come up with, and I mentioned this earlier in terms of things that have come up. So this concept of being able to offer appointments across the whole network. Okay, and many people are trying to understand what exactly does that mean. Is it that patient in practice A has to be able to access all appointments in practice B, or is it just that the appointments have to be available? And interestingly, so this is the word clarification, it doesn't say all in the document. Now, there has been a lot of interpretation that people have taken from the changes in the contract wording to suggest that it has to be all appointments. But as people have dissected this, it does seem that the word all is not in there. So potentially, and again, absolute definitive clarification from NHS would be very much appreciated on this topic, because I think lots of places are doing lots of changes around this. Does a patient in practice A have to be able to access all of the network appointments offered by practice B across their network or not? I'm thinking not. I think as long as you're providing some, that should satisfy the criteria of the contract. Absolutely clear. I'm not NHS England. But yeah.
Yeah, it's difficult, and clarification will be really, really welcome on that. I guess logically, and breaking it down to the patient level, from a patient perspective, I guess what's important to them is that they can access an appointment that meets their needs within network hours, so normal opening time out to 8 p.m. on weekdays and 9 to 5 on Saturdays. So from a patient perspective, and I think that's often where NHS England will be looking at things from, as long as they can access an appointment that meets their needs within that time, then I suspect that actually how that's implemented within the primary care network is going to be less of a concern, and it's more about whether the patient can access it. But again, let's see. I think we're just having one of those potential network issues again going on. So we can't see whether you can see us, but it looks like it might be coming back. Okay, so that's interesting. Just scrolling through the letter here, and really it's just restating the provision that will be available for extended access. And I think often these letters are written for other audiences, and this might be that they want patients or media outlets to know that access will be increasing and that there is funding behind increasing access to general practice appointments. So interesting. Then it moves on to things which are different. So from point 10 forwards, these are things which are actually new or different. And I think this is where we will take each of these points and we'll make sure that we cover these in some breakout episodes over the next few weeks and months. So the first one is it's saying that there will be some updated and limited expansion on the cardiovascular disease prevention measures that have been announced previously. And I must admit, I've not dived deep into the document to see what those are. And we're going to be doing that in the next few months, but that is something that they're indicating has changed and expanded. They're also saying a similar thing about early cancer diagnosis, although the word they use here is streamlining. So there's the potential for that to be made a little less cumbersome, big, difficult to implement than it may have been before. I don't know if you've dived into that at all, Gandhi. I know we've probably not had time.
No, unfortunately not had time to look at these two particular parts yet, but it is planned for the next coming weeks and stuff, so we will have that. So there has been elements of it, and I think they're just adjusting it rather than the cardiovascular one, which was actually paused until it started as of last week.
And they're also mentioning anticipatory care, saying that they will have clarified the requirements to move forwards for the measures on anticipatory and personalised care services. So I remember it took me a long time to actually get this straight in my head what they were talking about, because for us GPs, anticipatory care, we're often thinking about end-of-life care. But that's not what this particular measure is about. Do you want to just remind us, Gandhi?
Yes, so I think of this, and those of you who do remember this more along the lines of the unplanned admission DES that came about when Jeremy Hunt was actually our health secretary. So this was about 4 or 5 years ago. This is about trying to effectively prevent admissions to hospital. This is about supporting patients to make the right decision for their care and making sure that those more complex So hopefully you can see us and hear us. We really appreciate if somebody could let us know in the chat whether that's the case or not, because we don't have any feedback on that unless you tell us. So please stick in the chat if you can see or hear us. If you can't, I have written it in the chat as well.
Yeah. Sound has gone. I'm seeing us back on the screen again, so I'm hoping that we're back.
Yeah, we're back. Okay, awesome. Thank you. We're really sorry about that, guys. We don't know what's happening with the Wi-Fi. It does seem to be going a bit funny, and we are connected into the internet as well, but we are having to use Wi-Fi in addition, so that may be why we're having a little bit of issues. Really sorry about that. So we're going to crack on now.
Okay, so anticipatory care.
Yeah,
we were discussing, so plans have to be submitted in December for how primary care networks are going to address those requirements around anticipatory care, and we'll do a special episode looking at that as well. I remember having a lot of fun doing episodes around things like the care home elements of the DES and structured medication reviews and all sorts of things before. So I'm looking forward to doing another round of looking at those focused elements of the DES. And then, of course, there were, when we mentioned this before, we mentioned that in tandem, there are some requirements placed on other parts of the NHS to engage in anticipatory care measures as well. So the ICS, for example, has an obligation to do something around anticipatory care as well. And I think that will be really helpful, because I imagine that will entail some joining up of what the ICS is doing, perhaps around activities in hospital, in A&E departments. There's an opportunity to join that up with what primary care networks are doing. So I guess people need to start talking to their ICS and finding out what they're going to be doing as well about anticipatory care.
A while back, I remember saying live on this stream that I genuinely felt the personalised care and the anticipatory care elements of the DES, this is not something that general practice on its own can do. This has to be a collaboration between your ICP partners. This has to be a collaboration between your ICS. So pushing to the ICS, how are you going to help us support managing these DES outcomes? Because it is not, unfortunately, from my perspective, something general practice can do on its own.
And then in point 13, they're talking about 3 new IIF indicators that will be introduced in the new DES update. And those areas are focused around 2 areas. So that of DOAC prescribing, around the identification of new patients with atrial fibrillation and making sure that they are receiving anticoagulation therapy. And whilst we've not looked in deep in the document, I guess some of it might be about transfer of people who might be on warfarin or more older treatments for those conditions and might be better suited to a DOAC and moving them across. That's me just anticipating what might be there.
Well, the interesting component of that is that this controversy that seems to have come about, the fact that it's recommending one DOAC in particular, and that's unusual for such a high-level directive to happen when it comes to prescribing decisions. It's very rare for these, even NICE generally do not recommend individual drugs for particular conditions and stuff. It tends to be groups of drugs. However, NHS England have specifically specified that it should be edoxaban there is a criteria to transfer patients over. And a lot of people are questioning why. There is, from what I've heard, some evidence to show that edoxaban is slightly superior in some elements, but it's not conclusive as best as I can tell. And I would love for somebody to tell us, if they are watching, what they think of that in particular. And if they've got more information. And me and Andy, unfortunately, do not have the time to go through absolutely everything in detail, so we do not claim to be experts on that. But it is really interesting chatter around the fact that they have specified one particular medication for us to transfer all patients over to.
Yeah, I'd really like to know the answer to that question, actually, because I remember that the process of starting on a DOAC normally involves an element of patient choice, because there are some specifics around whether these medications can be taken with or without food, or time of day. That actually patient lifestyle factors have a big point, in determining what's best for them. And they're now just specifying one agent, so that's a little bit interesting. So because they say 3 points around these 2 issues, I'm just anticipating those will be the issues around DOACs, and then there'll be something around fit tests and early cancer diagnosis and cancer referrals for colorectal cancer as well.
So moving on, participation.
So just before we move on, so point 14, they're saying, okay, there's 34.6 million sort of new funding on top of that already announced to cover these new measures, so the new things that we've talked about there. And then participation, so just in case people are running around, it's the start of the new financial year, people are wondering if they need to get reconfirmation from their practices that they are continuing to participate in the in the DES, in the PCN DES, then that's not necessary. So existing arrangements roll over into the new DES, so you don't need to get new wet signatures to continue the collaborations around primary care networks. And then, as ever, it just reminds practices that if they wish to opt out of the PCN DES, then there is a mechanism for that, and they need to talk to their clinical commissioning groups about that. And that's really the long and short of the letter. As ever, I think they're quite interesting for where they choose to emphasise focus, and that can tell us a lot about what the NHS England wants us to be, what's the general public to be looking at the moment. And I'm really looking forward to doing some more detailed episodes in the coming weeks. I guess people could tell us what they want us to prioritise.
Well,
I suppose
they have been asking us some questions, Andy, so let's bring those back. Apologies again, everyone, that we did phase out for a brief period of time. So a lot of the comments do focus around the fact that we kind of lost contact. Don't know why. We'll figure that out hopefully in time. But we have got some comments. So Jez Cole talking about if we do what we do best and end up actually being good at this, which will be tough and professionally challenging, are we playing in the hands of those who want to disassemble primary care? Interesting, because many people are talking about the fact that the DES contract effectively is potentially a damage in terms of independent contractor status. Is it combining us as practices? And obviously the fact that the BMA have not approved this in terms of the GPC elements of it. So there is definitely some chatter around the medical political world around the justifiable nature of the new contract and how that works and what does that mean. We're still waiting for answers from the GPC in terms of what they're doing with this. There doesn't unfortunately seem to be a lot of information coming down in terms of the specific view to the grassroots, at the very least. There is information on their website and things of how they assess this. And actually, some of the other LMCs have done some amazing work at analysing the contract in more detail as well. Shout out to the BBO LMC. I know they've done some really cool work, which we will probably share in some of our upcoming streams and stuff. But yeah, definitely have a look at some of the stuff that comes out about this.
Yeah, just to speak on that point, really, I suppose the question is, or what appears to be happening is that the primary care network DES is a different mechanism for asking general practice to do things and contracting general practice and its partners, but largely general practice to do things in a way that doesn't require the same sort of negotiation that incorporating those into the core GMS contract would have done, and that might undermine the position of the GPC and how important those contracts have been historically, sort of divide and conquer. Not quite that, but it's interesting. I'd be really interested to know what people out there think about that. Do they think that that's what's happening? Is that a deliberate strategy, or is it just something that is a byproduct of what they're trying to do? Really interesting point.
And if you do want to let us know audibly, let us know through our SpeakPipe thing. So we unveiled this in our previous episode. If you do want to send a message to us where you can tell us what you actually think and literally tell us, then go to speakpipe.com/eGPlearning with the G and the P in capitals. And you'll be able to record something that we can hear, listen, and we may even use on the stream and stuff. Not necessarily, and if you don't want us to, let us know. More than happy not to, but absolutely a great way to share content with us. We're going to go through some of the other quick comments that we've had. So we had one about mental health workers. So where are we? Here we go. So let's bring that on the screen. So Raki Vaja, are your MHPs on 30-minute appointments? It does limit the number they can see. Well, mental health consultations are longer, generally speaking, and they are a different level of intensity and a different level of qualifications that they do in terms of GPs and stuff. So actually 30 minutes for a full-blown mental health consultation, depending on what you're doing, actually may not be a bad thing, particularly as a new contact. I think as a review may not necessarily be needed. Probably drop down to 20, I would imagine. But it does depend on training and stuff.
I think it really depends on what you're asking your mental health practitioners to do, because I know in our area we spoke with the practices and stakeholders and sort of identified that there were people who slipped between the gaps between our IAP services, improving access to psychology therapy services, and our local mental health team and sort of step 4 counselling. People sort of fell between that gap, and we really wanted we wanted the mental health practitioner to focus on those people. And actually what we find is those people are falling between that gap for all sorts of reasons. It's often because they're very, very difficult to help people that don't necessarily meet the criteria for specific mental health services, but nonetheless are really, really, really challenging with really, really complex social factors in there. And to really pick that apart, 30 minutes for initial appointment might not be enough to actually make meaningful progress. But so I think it largely depends on what they're doing. I mean, if they're sort of handling the sorts of low challenge mental health presentations that clog up GP surgeries, and that's the approach that you're taking in your primary care network, then 30 minutes might be too long in those situations.
I think it's that difference between first contact mental health practitioners versus mental health practitioners used to manage the localized challenges the practice may face. And this is definitely different to what we were originally told in terms of what the DES would be, and that's because of workforce challenges and stuff. But if you've got one person across multiple practices in your network, that's going to make it challenging to have a first contact service. If you're one of those lucky areas where you've invested in these prior to the DES and stuff, well, actually, great on you, to be honest. Really jealous. But speaking about supply and stuff, so Chris mentions any other areas without any MHPs at all due to lack of available NHS trusts. I mean, we mentioned locally in Nottingham that we've been told you're getting one and that's it. That's all they can provide.
I think some primary care networks might not have got one.
True.
As well. They've been having real challenges recruiting them. I mean, CPNs, we're in our area, we're looking at band 6 or 7 CPNs. I think the same nationally. There are not many of them around. They're in short supply, and many of the mental health services proper are crying out for them. So locally, I don't think all PCNs have got one yet.
And Chris is contributing further. So Edoxaban is the only DOAC the NHS have a price deal on. Or at least that's the reason stated in another webinar. So yeah, interesting on that point. Dave comments that RCCGs encourage Edoxaban, but based on cost, some deal arranged with the manufacturer, so I believe. So there seems to be some sort of deal done here, potentially.
That's the rumour I've heard as well. But again, I can't quite speak to the provenance of that. I can't quite remember where the actual source for that is, but it's something that people are saying.
Okay, and then Lisa mentions, I believe there is currently NHSDI, whatever the organisation is going to be called moving forward, piece of work about how to record care plans codes that carry into GP Connect and the summary care record. I did some focus work on this, but at present no recommended code set. Not sure how ICS can have consistent approach to relevant clusters of codes shared across England and NHS work in terms of them doing things and stuff. So yeah, interesting stuff. I think one of the real challenges that many practices are going to face is that there's so many different aspects to the DES now. And it is another contract, let's be honest. When you compare that to the GMS contract that many practices are working to, or PMS contract, there is so much to do. And we haven't even touched into some of the depth of the other things in terms of the IIF, Impact and Investment Fund, which is, as many people know, like the PCN version of the QoF. What I would direct people to have a look at and share with their practices. So one thing NHS England have done, which is quite nice, is a one-page summary of what the IIF looks like. And it's color-coded. And if we were really smart, we would have had that ready to share with you and show you on the stream right now. In fact, Andy, I don't know if you can have a look for it while we talk and stuff. But it's really worthwhile having a look at that. It is just simply a one A4 page summary. I would highly recommend sharing that within your practices because it just can help polarize the thoughts on what you need to do. Would you see that that's just another QoF? Absolutely, it is another QoF. Is there a way of making it easier? Well, there are definitely things you can do within your practice. I think there's amazing organizations like Ardens and Primary Care IT who have created loads of tools to help you manage these kind of things. And I'm sure there's local variations of those as well, and other things that you can have a look at and stuff. But ultimately, I think it is something that practices need to be aware of. And this isn't really something that the CDs and themselves can do independently and things. So do be aware that that is a resource you can lean on, and I might have a look for it whilst we go through the other bits because I think Andy's struggling to find it.
Yeah, I couldn't find it, so you might have more look there. But
okay.
But yeah, I think with the increased complexity of primary care networks and the DES now, I think most primary care networks, if they haven't already, really need a gear change in order to cope with this. The job of a CD and the job of the primary care network looks nothing like it did at the inception of primary care networks now. And things are at such a level of complexity that I think a network manager is an absolute requirement. Yeah. Actually, proper, meaningful engagement with practices on the delivery of the IIF and other elements of the DES is now needed to make a success of this. Things are too complicated, and so much of it actually just needs to happen in general practice now. It cannot solely be the area of the R staff to deliver.
Absolutely. Yeah. So for those that do want to have a look, I have stuck the link in the chat, and I've put it in the chat for StreamYard as well, Andy, if you want to bring it onto screen and things.
Oh, cool.
So we can have a quick look at that document and stuff. If you do find this document useful, give us a like. Let us know that this is useful stuff that you wanted to share and share with you. So if you are watching us live right now, please, give us a like on YouTube or wherever you
There we
are and stuff. And here it comes. Hopefully. There we go. Didn't click it hard enough. But yeah, so one page. So a lot of people have credited me for this document. I'll be very clear. I did not make this. I did not make this. I did not make this. This is actually NHS England doing something nice for us. And they have given us some extra tools this time round, which have been very much appreciated. And this is one of them. They have also shared with us the Ready Reckoner for networks and stuff, which we are going to go through in more detail in a separate episode. So do check us out when we come to that. We'll be talking about the pros and the cons of the Ready Reckoner and stuff. But like I said, this is a really useful one-page summary of the Impact and Investment Fund, which is, as we said, the PCN version of QoF. Speaking of QoF, shall we talk about QoF, Andy?
Yeah, I know some more information documents dropped about QoF as well, along with the rest of the documents. And I know that you've been having a beginning to have a look and pick that apart this morning. Is there anything that you've learned that might be of benefit for the EGP learners out there so far?
So we're going to couple of key headline points from the start of this document, and then we're going to go down towards the QoF QI element, which is probably the most significant change in the document. Important to know that the QoF QI outlines the number of points. I think it's 630. Sorry, the QoF document outlines 635 points at £205 and something pence. I've forgotten the exact number. Sorry, Andy.
It is at the head of the document.
Yeah.
I'm heading back there.
Okay.
Yeah, 207.56 pence.
Yeah,
365. You're right on the QoF points.
So it's
the same, I think.
Yes, that's based on an average population 9,374 patients. They have pretty much said that there's no major changes to the QoF criteria in terms of how you achieve the points, aside from the QoF QI, which is now changing to look at two different domains compared to previous years. So previously, this has looked at things like learning disabilities. It's looked at early cancer awareness and diagnosis. This year is focusing on prescribing in terms of drug dependency and access to general practice in terms of optimizing and things. And this is basically 37 QoF points in total for each domain. So that works out approximately, if you go on the £207 per point, it's about 7,700, just shy of, in terms of per domain, per QoF QI, so approximately 15k of funding for practices. So it's not a small amount of money. It's not a big amount of money as well, but it's enough money to make you be aware of the work that's involved. And I will be clear, there is work involved in this, okay? So we're going to go through what that is and stuff. But as Andy's got it on the thing, so basically the first thing you have to do for the prescribing drug dependency, and we'll read it out for you. So the contractor can demonstrate continuous quality improvement activity focused upon prescription drug dependency as specified in QoF guidance, and we'll talk about that in a second. And then that gets you 27 points, which is the majority of it. The remaining 10 points is that they've then participated in network level discussion at least twice, is what it says, over the QoF year, and how that has led to some element of improvement across the board. Okay, so that 10 points is the same both for this one and for the following elements in terms of GP access.
Gandhi, do you welcome the inclusion of this as a QI indicator? What do you think about this one?
So we're going to get into this. I think the drug describing one is something that is important. I think it's very challenging, and I think many practices are going to struggle in terms of trying to achieve some parts of it, because it's a really difficult area to tackle clinically. But out of the two, that is the one I think is the most sensible in terms of action and impact. Having said that, the access one, I can understand why they've done that, because as everyone keeps telling us, access to general practice is not what people want. And there is a focus on trying to look at want versus need. Talked about demand versus capacity in terms of that and things. But I do think the access one is a bit more challenging to achieve and stuff. So, okay, let's have a look at these in a bit more detail though, shall we? So if we scroll down, it talks about, as ever, stuff, QoF improvement and that kind of thing. So we haven't highlighted this document. Let's be clear on this. Is NHS England that has highlighted this document. It does have quite a few resources for you to look at from various organisations like Health Foundation, the RCGP, other places and stuff. Go down, Andy. Yeah. And in particular, it does reference to a lot of documents on the RCGP website in their QI portion of the work that they do. So you may even have to register with that. And I don't know if you need to be an RCGP member in order to access that. I don't think you do, but I am an RCGP member and it let me in. So Yeah.
I'm a member as well, but I've not tried to access those particular resources.
Interestingly, though, I didn't use my membership to actually log in. So I used a separate email address. So I don't think you have to be a member, but it does reference a lot of documents that sits behind a RCGP QI paywall kind of thing that's not involved in money as far as we can tell, but you may just have to register for that. When we talk about drug dependency, it is quite broad. I'll be very clear on this point. So it talks about looking at particularly medications of, I've forgotten the phrase it uses, dependence-forming medications, DFMs. So if you see that acronym, that's what it means. DFMs means dependence-forming medications, and it picks the big ones that we all are aware of. So opiate medications, which forms the bulk of it, I think 13%, gabapentinoids, benzodiazepines, and then the Z drugs, so the sleeping drugs and stuff, and they form in terms of the amount of prescriptions generated across. In total, they form, according to the NHS England, a 21% of drug prescriptions issued across the whole of England.
Wow.
So a huge chunk, that's not an insurmountable amount of prescriptions and things.
Yeah, often overprescribed. I know we've already been doing a bit of work locally, encouraged by our CCG pharmacists largely, and the helpful changes to the NICE chronic pain guidelines that occurred last year. I'm quite pleased to see this as an area of focus, actually, for the government and for ourselves. And I've been beginning, I don't know about yourself, Gandhi, to have a little bit of success with some patients in terms of reducing their opiate load, for example. And I'm quite, I wouldn't say excited, but I'm quite interested to see this as an area of focus, because I think it's actually an area where we can begin to gain some traction, particularly if all GP surgeries are giving the same message, particularly for those patients that can move around if they don't get what they feel they need from one practice, they'll move to the next. And also that kind of things have such a profile that all members of the team are aware of the focus on the issue, and often attaching some funding to that is the way to make that happen, and to make sure that practices brief all their staff about things. I think it's an area where we could make some improvements. And actually those patients where we've been reducing their opiate load, actually they do seem to be doing better. I think of a few particular chronic pain patients where we've really focused on reducing, their Zomor for their oxycodone prescriptions, and they seem to have a better time of life. So I think this might be an area where we perhaps could make an improvement.
So just to go through what you need to do, so it does talk about 4 key areas that you need to have a look at in terms of achieving the QoF QI, and in particular, if we go a bit further down, so it talks about reducing the prescribing, 5, reducing initiation of prescribing medicines that cause dependency, reducing the duration of the courses of the medicines themselves that may cause dependency, increased uptake of non-pharmacological support for interventions, improved patient understanding of the potential benefits and harm and stuff with the medications, and non-initiation of other medication groups, in particular identifies ketamine and quetiapine, because they are potentially sedating drugs that can have similar impact in terms of the opiates and stuff. So it's looking at those particular outcomes and stuff. In terms of achieving the QoF QI itself, there are definitely 3 things. So you need to evaluate the current way that you're prescribing, so some sort of QI improvement in terms of how practice is currently doing, and then looking at an improvement project to look at that. Doing a review of all patients on 120 milligrams or more of daily morphine use. So definitely a search that's doable, and I would highly recommend, if not haven't already done it, a lot of these organizations have probably created these searches to help practice identify these patients on high opiate doses and stuff. And then also doing a review of patients who are on multiple medications, dependence-forming medications as well. So if they're on 2 or more, and then 3 or more, and how you can approach those and stuff. And then creating a plan to improve that. Implementing the plan, that's step 3. Participate in 2 discussions across your primary care network to look at that, and then complete the QI monitoring template, which we'll show you in a second and things.
Sounds worthwhile to me.
Absolutely sounds worthwhile.
Yeah.
Interesting thing it recommends, and it does identify that those areas of high health inequalities have higher rates of prescriptions of these particular medications. I think you and I would probably attest to that in terms of the populations we look after, that we probably see higher elements of this. And as a result, there's then the question of what resources do you have to support these patients? That's the part it doesn't talk about at all. It hopes that you've already got those in existence, or you've got other things to support patients with.
Yeah. Okay. Yeah. But I suppose there's some, there is some QoF funding associated with it, but I guess you get that on completion, not ahead of time. I know we've done some of these searches already, and I would say I think it's been a useful exercise.
Yeah.
Before doing it, I thought, gosh, talking to this group of patients that are on high amounts of opiates, suffering with chronic pain, I thought actually it might be difficult to make an impact, but actually, in some with some patients, it's actually made a real impact for them for the better.
And I think it's really important not to underestimate the impact that can have. We know that particularly opiate use, it can have a huge issue in terms of bowel implications, because that's a common side effect. But in terms of hyperalgesia, so they can have an increased pain response as a result of it. They can have impact in terms of dementia, cognitive function can decline as a result of that. Can increase risk of falls, obviously that can increase risk of fractures. There's a huge implication in terms of the long-term use of opiates, and we know that multiple dependence-forming medications, as they now use the term, in combination with things, increases the driving risk. Reminding your patients that if you're taking some of these drugs, you may not be safe to drive, and actually you are maybe liable if you were to have an accident whilst taking these medications and driving as well. There's an element of that needs to be considered. But absolutely, I think the work itself is anything. One of my things I've been trying to do for the past couple of years, similar to yourself, Andy, is trying to reduce the chronic use of opiate medication. Important in terms of chronic use of up to 3 years. So whilst it says 3 months to 3 years is considered, towards the chronic element of use for medications and things. So being aware that this doesn't mean that you shouldn't use the drugs at all. It's just very much focusing on that they have their appropriate use, and you should use them in those situations. And particularly the ongoing use of these medications should not be considered. How each place does it? Well, there are a couple of examples it identifies a little lower down in terms of some of the SMART objectives, and it keeps coming up about this, this term of using SMART objectives or SWOT analysis to evaluate how you're going to do these kind of different areas and things. But where are we?
Creating an improvement plan.
Yeah. So the aims, measures, it talks about, like I said, SMART documents and stuff, and then just a little bit lower down, it's got some examples for you. So, area for improvement in area 1, this is about your awareness within your staff, a baseline staff survey, considerable variation in confidence, and when it comes to alternative options in terms of prescribing for patients with chronic pain and parallel variation. That's the part I'm struggling with. What are the alternative options that we have in some areas? Because we don't have any. I don't know about you, but I don't have anything really.
Yeah, it's difficult. I mean, a lot of this is about physical, increasing physical activity. I think is really, really helpful to go hand in hand with reducing their pain medication. It's those sorts of psychological and activity interventions. It's difficult. I mean, often you can use what's already there in terms of IAPT services, but I think physical activity interventions are really, really variable. I guess that's where your health and wellbeing coaches might come in from a primary care network response. And I know, I think I've seen some really good people recruited into those roles actually in primary care networks, and that seems really, really promising. So I can see we've got the beginnings of some resources to do more in this area than we have in the past.
I think it's important to emphasize that it does maintain that throughout this, that you should be using the available staff around you. This is not just GPs to do. So absolutely your clinical pharmacists should be involved in this. Your medicine management teams absolutely would be useful to have included in this. And like you say, other aspects of the things like health and wellbeing coaches.
Yeah.
Outcome 2 is reducing the number of patients on 120 milligrams of morphine or more in total daily use. So that's basically just doing a search, identifying those patients and supporting them in terms of potentially making changes away from opiate-based medication. Option 3 is that reducing the number of new prescriptions for these kind of dependence-forming medications and stuff, and what process have you put in place? So is that doing a search? And it does mention about doing somewhere in this document an audit process for at least about 4 weeks in total. So important to recognize this is going to take a bit of time and effort and a bit of planning as well. We'll come to the timeline for that in a second. And then the 4th one is looking at differences in drugs. So you could potentially pick patients who are taking benzodiazepines with opiates or Z drugs with benzodiazepines. That's a really chaotic combination of things. And, seeing if they've had repeats issued within, a 3-month period or something like that. So just to outline the timeframes, and this is going to be similar for the next outcome. Basically, you need to start doing this now, is the long and short of it, because effectively what you need to do, you need to have a discussion at the very least within your practice, if not within your network, to identify what criteria you're going to be looking at. I would highly recommend doing that as a network, so then you're all looking at the same thing, because that makes the subsequent discussions a lot better. And we saw this with the QoF QI in previous years as well. You then have to do some element of QI work, searches, that kind of stuff. And again, this is where you can lean on some of your other roles within your teams. You know, your pharmacists, absolutely, your network pharmacists. This is a key thing for them to be looking at, in addition to obviously some of the IIF impact stuff and things. And then, you know, how are you going to review those patients? Initially, I'd probably just do the searches first to establish how much you've got, have that initial meeting and what the plan is going to look like from your network itself. And then, you know, so aiming probably around about June time to have that initial meeting at the latest, I would imagine. Go off, do the work, because you need a good length of time to do some of this stuff, particularly that 120 milligrams of morphine patient workload. That's not something that's going to change overnight. That is going to take several consultations to support these patients and also to look at the changes and stuff. And you need at least, this suggests 3 months worth of data. To be honest, I'd probably recommend you probably need a little bit more time to do some of this kind of stuff. And then obviously you'll need that review meeting. So you're looking at that review meeting probably end of the year, if not sooner potentially. But I suspect most people, as usual, will end up having in January, February time. But then that will give you the opportunity to fill in the rest of the document. So if you scroll down to a bit further, Andy, we've got a little document from them that the table document. So there's more details there what you want to look at.
The reporting table.
Here we are, the reporting template. So this is a template you have to complete in terms of submitting it back to your local area. So I'm assuming it'll be the CCGs, and this is the one that also needs your PCN clinical directors sign off somewhere at the bottom that says that you've actually done this. So this is the document that's filled once you've had at least that second meeting within your network.
That's good. It's interesting. It says maximum of 2 sides of A4, Arial font size 11. So it's not wanting huge amounts of data in there, really just the headline achievements. Yeah, I think we're getting used to doing these sorts of quality improvement cycles now for QoF and within primary care networks. So I think it's a process that we're becoming familiar with. And the outline that you've described there, you know, basing the searches around 2 primary care network level meetings sounds really, really sensible to me. Have we got more information about extending access?
So let's not get confused. This is not extended access. This is separate. This is optimizing access to general practice. So this is the second QoF QI indicator. Now, I'll be honest, I haven't looked at this one in as much detail.
Maybe it's one for another. Maybe it's one for another video.
No, there's interesting stuff to be aware here. So it does talk about various different criteria that you need to have a look at.
Tell me and
if we go down to page 102. So the overview is pretty useful in terms of the ABC criteria here. So undertaking a review and practice and the PCN to understand the better skills available across your team PCN to better match and optimize user capacity, including your various different roles, the CPCS scheme, and that kind of stuff. So basically, it wants you to do a review of what you currently have available within your practice/network capacity in terms of the appointments you're offering. So that kind of sounds sensible, doesn't it? How you do that assessment? Okay, again, you probably need that discussion within your practice to understand that you're all checking the same thing, because every practice has different appointment routes and methods and stuff. So you're going to need to be able to understand how that currently works within your practice and network areas and stuff. Then, working with your practice, patients and carers to understand the views around acute issues, including ease of contacting the practice to obtain advice or an appointment, communication including website, local population at risk of inequalities with regards to access, and to co-produce an access improvement plan. This is the key part. Co-produce. So for those that don't know what a co-production term means, because it's a relatively new term that's come up over the past year, this is in combination with your patients. This is not something that you as an individual practice can do. This is not something that you as an individual network can do. This has to be done with your patients. So your PPGs are probably a really good place to focus on in terms of engagement and stuff, and you may have to include them in some of your meetings to discuss what access and improvement looks like. Is that done at a practice level? Is that done at a network level? Okay, you're going to need to figure some of that out.
As long as it meets the needs of the population, probably either would be acceptable, I would suggest.
But important to focus on, there needs to be this level of discussion with patients about what this looks like, because you need that evidence to then show that you've done some sort of change in combination with the patient's understanding of how this works. Then considering access beyond the practice by reviewing links, pathways, parts of the system beyond the practice, i.e. in PCN, e.g. local authority, third party services, and that kind of stuff, collaborative working. So, this feeds in a little bit into the anticipatory care stuff. There is some blend over from what I can see in terms of this happening, but this is potentially, from my perspective at the very least, this is a harder piece of work, I actually think, because this is less clinical. This is more about ethereal stuff, and this is more about reactive stuff, and potentially more emotive stuff, because we know that general practice access is an exceptionally emotive topic, as we have seen over the past few months and stuff.
Yeah, I think it's difficult. It's hard to see how you would make an impact with this, but I guess they're outlining the mechanics of what we need to do, and it may yield some useful information. I think it depends how well you implement it locally. I would just say, in terms of working with patients in co-collaboration, I've had good experience of using patient surveys, actually. Just think of some primary care network working groups that we have around healthy lifestyles, for example. It's so easy now to create a survey using Google survey tool, or the one that's included with Microsoft 365 that we all get access to,
forms,
via our NHS subscriptions, and it's come along a long way in the last few years, and it's actually really, really helpful exercise. And maybe we could even do an episode about that, just to spell it out for people.
Absolutely.
How to do it.
And there are some additional tools you can even look at. So I know lots of the providers are looking at additional ways to help you, Ardent's, Primary Care IT, Accurate, all kind of stuff. There's the built-in questionnaires in System 1, which is a really useful function that you can now use, particularly to get one-to-one patient information. One thing I would recommend people have a look at, so people are asking for resources to help them. They have included one in here, and you are welcome to check out our review of that particular resource. So that's the London partnership document. I've forgotten the exact name. London General Practice Access Guide and Manual. So if you want to have a look at that episode, so we did this about 4 months ago with Dr. Min Albakai, who works at NHS England Digital
Innovation,
whatever it's called, and stuff, as well as with the local London partnership. And this is the document that within the DES they reference on multiple occasions, looking at how you can tackle the QoF QI elements for optimizing general practice access. So have a look at that document. If you want to watch the video that shows you the document detail, feel free to check it out on eGPlearning for yourself as well. It does then talk about creating an improvement plan, and there's lots of detail here in terms of how you can do that. A bit further down, Andy, so I think about a page and a half down. Demand and capacity it focuses on initially, so various different aspects. You can reduce rates of consultations, repeat appointments for the same issue. In particular, it talks about patients waiting long waits for appointments and that kind of stuff, and various other aspects in terms of reducing contacts at different places. It talks about patient satisfaction. There was talk about this patient satisfaction stuff before, if you remember, and it's sort of in there in the IIF as well. But how do you improve access? And that may be where, like Andy mentioned, some of that form stuff comes into place. And then utilizing wider support, so the CPCS scheme and other kind of schemes and stuff that may exist in your local area, and looking at a review of those kind of things. Then again, talks about SMART goals, some examples here in terms of you can search for particular populations. Important to remember that there's a focus on health inequalities as ever, running through the themes of the IIF and various impacts. So picking a particular population in your area that may have more challenges in terms of access would probably be a really sensible thing to go for. So patients potentially with learning disabilities, patients of non-English speaking backgrounds and that kind of stuff. How are you tackling those particular health inequalities to improve their access to care and things? And then education seems to come through in terms of this, to then have an outcome in terms of the timeline. So there's lots of information there, so much more that we haven't actually had time to go through it all in detail. But if we go down way down to the bottom of the plan and stuff, because as ever, you still have to do that. So just important to remember, have a look at this now. Do not wait 3-4 months to do it and stuff, because if you do, you're going to find this incredibly more stressful. So whilst you've got that brief 2-day holiday from QoF that we all take after the 1st of April and stuff, this is the time to have a look at it and things. But then, it's picking the areas you want to focus on, picking those health and quality areas you want to focus on in terms of access and stuff. And what does your access project look like across both your practice and your network area? Have that discussion soon. work towards the same outcomes in terms of what you're evaluating within your practices. That's probably the most bang for buck in terms of what it looks like. And maybe with looking at individual challenges practices may have, because that's going to be a variation aspect I think many of us probably include. What's a smart aim? How did you test it? What changes have you made as a result of that? And have they been sustainable and have they had an impact? That's basically what the document's asking us for and stuff. And then what does that look like in terms of the discussions you then had within your network? And again, you're probably working to that similar time frame. So aim for your first meeting to be May, June time, your second meeting to be towards December time, ideally at the latest. And then if you need additional stuff in between that may be based on your own local networks and things. But hopefully there's some extra resources there to help you in terms of things. And this one is a shorter reporting document. It's only just over 1 page compared to the other one, which was obviously 2 pages in totality. So yeah, lots to cover there. We hope you found that really useful and effective. We've pretty much hit our time, and apologies for the pause that we had in between. We've had, I think, some extra comments and stuff. Can we add the documents to links? Yeah, we will do. We'll put all the links in it shortly afterwards and stuff, so you can have a look at those. As we mentioned, over the coming weeks, myself and Andy are going to be picking apart these various different documents that you've seen and trying to give you our perspectives. That may be together, that may be separately, because there's so many of them. If we're to do them both together, to be honest, it's going to be June, July by the time you actually get these documents and stuff, but we will be covering them shortly. So please let us know what you think. And if they are useful, again, please leave us a like down below, because it does help us from the metrics, from all the stuff. And also let us know that we're doing a reasonably nice
It's great to get feedback. If people have any other areas that they'd like us to focus on or look into, then let us know, or people just want to encourage, then that's really, really welcome as well.
As always, if you do have any comments, questions, let us know. We'd love to hear stuff and things in terms of what you think about this stream and other stuff that we've been doing. Definitely, if you're interested, sign up for some of our courses coming up. We've got some awesome things coming up, as well as potentially the new System 1 Facebook Users Group Conference, which we'll be planning for the summertime, maybe even hybrid. We're looking at it, people. Yeah, we're going hybrid. Let's see what that looks like, shall we, as ever? And just let us know what you think. And if you want to check out more content, it's probably coming up right here, as ever. Shall we say goodbye, Andy?
Yeah, goodbye. So what do we say?
Catch you later.
Bye.